a 62-year-old male heavy smoker and alcohol user, presents with progressive dysphagia to solids and significant weight loss. I am showing you his lateral chest radiograph and an axial chest computed tomography scan. Describe the findings.
The lateral chest radiograph demonstrates abnormal widening and thickening of the tracheoesophageal stripe, which measures approximately 9 millimeters in width, along with mild anterior displacement of the trachea. The axial chest computed tomography scan confirms marked, concentric wall thickening of the thoracic esophagus, narrowing the esophageal lumen, with loss of the fat plane abutting the posterior tracheal wall. These findings indicate an obstructing esophageal mass, with esophageal carcinoma being the primary diagnosis.
What is the normal upper limit of the tracheoesophageal stripe on a lateral chest film? And what are the two most common histological types of esophageal cancer?
The normal tracheoesophageal stripe should measure 5 millimeters or less in width. A width greater than 5 millimeters is abnormal and should raise immediate suspicion for esophageal carcinoma, though achalasia or severe strictures can also cause it. The two most common histological types are squamous cell carcinoma and adenocarcinoma, which together account for more than 90% of esophageal malignancies.
Contrast the primary anatomical locations and risk factors for squamous cell carcinoma versus adenocarcinoma of the esophagus, and name the most common benign esophageal neoplasm.
Squamous cell carcinoma typically affects the upper and middle thirds of the esophagus and is strongly associated with smoking, alcohol abuse, achalasia, and tylosis. Adenocarcinoma characteristically involves the lower third of the esophagus and the gastroesophageal junction, arising in the setting of chronic reflux disease and Barrett's esophagus. The most common benign esophageal tumor is a leiomyoma, which is a smooth submucosal lesion. For staging, I would recommend endoscopic ultrasound to assess the depth of invasion and PET-computed tomography to look for distant metastases. I would refer the patient to gastroenterology and thoracic oncology.